Hello, this is Dr. Mark Rosen, and welcome to Critical Care Ultrasound Vignettes, case number 4. This vignette, like all others, is from a real patient and serves to illustrate how ultrasonography can be useful in the intensive care unit or the emergency department in making clinical decisions and diagnoses. In case number 4, you're called to the bed of a 59-year-old with sepsis who is now hypotensive. He's awake but slightly confused. His blood pressure is 96/52, pulse 120, respirations 22. He is febrile at 38.1, and his pulse oximeter is at 90%. His general appearance is that of a patient in no acute distress, but is slightly confused. His heart reveals a regular rate and rhythm without murmurs. His heart sounds are not distant. Lungs are clear. His abdominal exam reveals a soft, non-tender abdomen with normal bowel sounds. The neck, no JVD. Examination of the extremities reveals no edema. His distal fingers and toes are cool bilaterally. His neuroexam reveals a slightly confused male who is conversant, and there are no lateralizing findings. As part of your evaluation, an ultrasonography exam is utilized. Multiple cardiac images were obtained in this case. So let's first look at these images and decide what type of cardiac view was performed and what abnormality, if any, was seen. This is image number 1. What view is this, and is there any abnormality? Now let's take a closer look here. Image number 2. What view is it, and any abnormality once again? And once again, we'll take a closer look at the heart by having additional imaging. Here's image number 3. What view is this, and is there any abnormality? And then one last time, we'll take yet a closer look at the heart for a more detailed examination with one more view. Image number 4. And the same question. What view is it? And then, of course, that's followed by the second question, any abnormality? So, did you make the diagnosis? Pericardial tamponade. All right, let's review the images. They're from 4 different cardiac views to get the best view of the heart. First, let's review the different aspects of image 1, starting with basic landmarks. This is a parasternal long view. And here is the left atrium. The mitral valve is opening and closing over here. Blood then flows into the left ventricle. Here's the outline of the ventricle. Goes out the aortic outflow tract here. The septum lies between the left ventricle and the right ventricle, with the right ventricle noted right here. Now, what's this over here? And then a second question, similar one. What's this over here? There's a large circumferential pericardial effusion, which goes around the heart here, continues off the screen, and then comes over here as well. And what's this landmark here? That's the septum. But notice there's poor septal motion, and the chamber over here, again, if I put my arrow in the middle of the left ventricular chamber, it should seem like all walls are collapsing around it. There's not that much collapse from the septum, so there's poor septal motion as well. And this arrow here is looking at the wall of the RV, which appears to be collapsing. A slightly different view of image number 1 helps clarify the situation somewhat. There's a much better view of this pericardial effusion here at the bottom of the heart and up here at the top of the image. And again, the septum is not moving very well, and the right ventricular wall is collapsing. Now, it's always important to measure the size of the effusion. We could use calipers, or we could get a quick estimate by just taking the measurements at the scale over here. Each hatch mark is 1 centimeter, so this is clearly greater than a 2 centimeter. It's almost 3 centimeters. Greater than 2 centimeters illustrates a large pericardial effusion. Now here's image number 2. This is a parasternal short view, which can be obtained by doing a parasternal long and rotating the probe 90 degrees. We climb from the apical view to the mitral valve and to the aortic valves, so let's take a closer look at that. First, we start off down at the apex, move up to the mitral valve, and now here's the aortic valve coming through. Apex, mitral valve, aortic valve. And this clip reveals a rather large circumferential pericardial effusion, extremely large towards the apex down here. And again, we can see the collapsing right ventricle. Here's the RV over here. You'll note that the heart is swinging back and forth right there. That's what gives the appearance of electrical alternans. Let's look at the apex again, and there's the swinging heart. Now if we look at clip number 3, this is a 4-chamber apical view. There's a huge circumferential effusion here going around to here, and that makes the cardiac borders quite hyperechoic due to a good acoustic window. We note again RV diastolic collapse here. In looking at the subxiphoid view, once again, we can measure or approximate the size of the pericardial stripe, and there appears to be a 5 centimeter pericardial effusion. And we can note collapse of the RV here at the arrow. So what's the take-home message? Of course, pericardial tamponade can present in many fashions, one being hypotension. Beck's triad of muffled heart tones, jugular venous distension, and hypotension occurs in a minority of cases and is therefore unreliable. It occurs in approximately 25 to 30% of the cases only. Cardiac imaging for tamponade, as with all ultrasonography, should be performed with multiple views. And we can tell from these 4 views that there were certain views that showed the effusion to be much larger than other views. Ultrasonography is a rapid, simple method of diagnosing pericardial tamponade. For more details about pericardial tamponade, please go back to the didactic lecture entitled Ultrasound, Cardiac Effusions and Tamponade. I hope this vignette was useful for you. Thank you.